Thank you so much, Loretta, and thank you for the kind invitation to the School of Public Health at Boston University, where I used to come for my violin lessons 40 years ago. It's kind of funny to be back like this. So I want to talk about housing. I want to talk about the relationship between housing, health, and equity. And the relationship between housing and health is actually now very well established, thanks to a great number of studies over the past 20 or 30 years. There's a lot of literature on housing as a platform for well-being. There's a ton of work on the social determinants of health, looking in particular at neighborhood quality. I argue that there's not enough attention paid to stability, to the idea of stability, community stability, as one key to health and the ability to thrive. And I know, actually, I'll give you a preview. This is going to relate directly to what Bernadette's going to talk about in a moment. You know, having a place to come home, having a place to experience joy. Those types of experiences are really key to health, and both physical and mental. So I'm going to talk briefly about displacement first, actually. The issue of forced displacement, the issue of voluntary relocation to the suburbs, and what that means for health and equity. And then I'm going to talk briefly about data and our issues with data when we study housing and health. And then I'll speak very briefly about policy, what we should do. My research lab is called the Urban Displacement Project. It's still at Berkeley. It's moving to Toronto, so we're about to be international. But we work on evictions and displacement. So you could think of evictions, as being forced to leave by the landlord. We call that a hard eviction. But actually, that's just the tip of the iceberg. Most displacement occurs from what you might think of as soft factors: a raise in rent, landlord harassment. Oh, I'm going to raise the rent next year, by the way. Or just poor housing quality, not maintaining the plumbing and this sort of thing, making the place unlivable. So both hard and soft evictions, whatever way it happens, has health impacts. So after being displaced, residents are forced to make very difficult trade-offs when searching for new housing, and these impact their health. And some examples of those trade-offs that they make: you may have to move into a housing unit of lesser quality. That has implications for health. There could be pests, mold, allergens, exacerbation of asthma, and so forth. Another trade-off that people make is moving into crowded units. So crowding negatively impacts mental health. It increases the risk of exposure to respiratory and infectious disease, and so forth. And then the third trade-off that people make often is just paying more for rent. And often when you pay more for rent and you have a fixed household budget, you cut down on healthy food, you cut down on healthcare and medications, you cut down on childcare, other types of factors that are really critical for health. Also, after being displaced, households tend to move to neighborhoods with fewer resources, fewer job opportunities, more distant from work, costly commutes, more environmental hazards, safety concerns, fewer healthcare resources, fewer nonprofits, and so forth. So displacement is traumatizing for families, and I think we really have not spent enough time really exploring those health impacts. In terms of voluntary moves, I think there's also kind of a misconception of the opportunity that low-income households experience when they move to the suburbs. So there's this idea that suburbs are high opportunity areas. And a lot of this is coming now from the work of Raj Chetty, whose brilliant work has shown the upward mobility that comes from moving to the suburbs, and looking at the zip code level. And I don't dispute that work, but there's also a number of studies, and a lot of this work comes from the early moving to opportunity studies, looking at folks moving out of public housing projects into the suburbs, using housing vouchers. And often, in terms of health, those outcomes were actually not that positive. So often the asthma or mental health conditions, depression, fear, anxiety experienced in public housing were just replicated in a different form in the new suburban neighborhoods that they moved to. This is from the Hope 6 panel study for those who are curious. In general, there's no improvements for hypertension, physical mobility, asthma, et cetera, after you move to the suburb. And there's also mental health issues particularly among adolescent males that have moved from the city to the suburbs. There are mental health improvements for adults. And there are other benefits, but I'm just focusing on health. So in sum, the suburbs don't really seem to be the panacea that a lot of our policies are kind of making them out to be. And so we often justify the redevelopment of the center of the city for higher income users with the idea that fair housing will be in the suburbs. But that I would argue that actually fair housing opportunities may be just as prevalent in this core of the city as in the suburbs, particularly from a health perspective. So a couple comments on data and policy. So when I realized I was coming to speak at a school of public health, I have to confess, I am so jealous of health researchers because of the administrative data you have, because of the individual level data that you have. So you understand individual health histories, and more we can make individual health diagnoses based on individual health histories. Well, guess what? When you're studying housing, you don't have individual data. For the most part, you know about neighborhoods, you know about census tracts or block groups, you know about groups of 4,000 people. So imagine trying to make a diagnosis for stomach cancer based on an average of 4,000 people in a neighborhood. That's what we do with housing data. And so in many ways, housing policy is still in the dark ages, until we can get individual data so that we know which individuals are living in which types of units and what their outcomes are. We won't know much about housing, and we won't know much about health, and we won't know much about how they're related. So this ecological fallacy, as we call it, this study of urban phenomenon using aggregate units has really held the field back. And I think I would like to see more collaborations between health and housing researchers to really address that and move that forward. And I'll just wrap up by talking a little bit about policies. So because we don't have good data on housing and individuals, we're not really making good policy. We just did a review article on anti-displacement policy, and we looked at 40 different housing policies and their potential to reduce displacement. So guess what? There's no evaluation at all of any of these policies in terms of their effectiveness of mitigating displacement. Nothing. Okay, we don't do evaluation in housing. It's kind of shocking from a health perspective. So this means that we really don't know what works. We don't know what works best in which context, and we're operating in the dark. So then, Barbara spoke earlier about mistrust, institutional mistrust. Well, think about your local housing departments and what how they're making policy. I mean, at least we had some data on vaccines that emerged over time. We don't have the data on housing outcomes. in that, with a few exceptions, but in general that is out there in the public realm that can be relied on in particular contexts. It doesn't exist. So our local policymakers are sort of making policy in the dark. So I'm looking forward to a new generation of housing policymaking, housing research, working in tandem with health researchers. So thank you very much.